A very good evening, everybody. Good evening. Okay, so let us. Okay, so I hope you enjoyed the beginning, and once you have enjoyed the beginning, we will start with the orthopedic imaging, and let us have a plan and let's see what we have done so far. Okay, this is what we have done so far. If you remember, we started with. Okay, so if I take the liberty of taking a small checklist. Okay, we started with CT scan, then we went on to what is MRI, then we saw neuroimaging. Done. Then we spent a lot of time on chest X-ray. Done. Now we are starting with orthopedic imaging. And I have already begun the tumor part. I've already started to tell you about how the tumors look like, and we've already talked about it. Okay. Everybody okay with this? Okay. So once you are okay with this, just on your special demand, I am playing my video. Okay, just especially for Kinnell because she has been asking so good doubts. I didn't want her to miss out on this initial part of the class. Now let's start. Okay, everybody. Now, so we have seen all this so far. Okay, so in bones, we started with bone tumors. And I have shown you 5 principles of looking at a bone tumor. We started with looking at the age of the patient by looking for growth plates. We started by looking at the location. We started at pattern of destruction. Remember the words geographic, permeative. We started with looking for matrix, looking for cortical break, and looking for periosteal reaction. Okay, this is what we discussed yesterday. Okay, everybody clear? Okay, this is what we discussed yesterday. Now what I will do is today I will go forward and show you more tumors. Like yesterday we saw tumors like osteosarcoma, chondrosarcoma, Ewing sarcoma. Okay, these are the 3 images that we have already seen in the class so far. We saw, okay, osteosarcoma, chondrosarcoma, Ewing sarcoma. Now what I will do is, okay, I will now start with the class. Okay, everybody who is asking how many pages. So what we have learned in this lockdown is the most important question that the students have in the entire lockdown is, anybody? Bolo? How many pages? Okay. So we have seen the most commonly asked question in the chat box is कितने पेज हो गए Okay, so अभी कुछ भी नहीं हुआ. I'm just starting. Okay, I'm starting today with the first image of the day, the first page of the day. Now look at the first image here and tell me, is this an X-ray of a child or an adult? This is an X-ray of a adult. This is an X-ray of a adult. Tell me, how do we know adult? We get to know adult if we don't see any growth plates. So if you notice here, these are your joint spaces, but no growth plates are visible. Okay. Where is the disease located? Disease is located in the phalanx. Disease is located in the phalanx. Okay. Where is the disease, beta? Please tell me, where is the disease? This is your disease. Okay, I will zoom it. So when I zoom it now, can you see in the phalanx, you have a well-defined, well-marginated lytic lesion? Okay, can you see it here or not? Yes, we can see a well-marginated lesion. If I see a well-marginated lesion, we will call it geographic lytic lesion. Yaad hai? Remember I told you how to describe a bone lesion? So in an adult, in the phalanx, you can see a geographic lytic lesion. Geographic lytic lesion, beta. Now, any one of you can answer, beta. Any one of you. When I see geographic lytic lesion, what does it imply? It starts to tell me that I'm looking at a benign lesion. So in a benign lesion, how will I confirm that this is benign? So please look at the cortex. Please look at the overlying cortex. Do you think the overlying cortex is broken or intact? There is no cortical break. Again telling me that we are looking at a disease which is well marginated. And plus there is no periosteal reaction as well. Further telling me that the disease is limited to the bone. Okay. So I hope you can see how we are able to guess on the X-ray that this patient has a benign lesion in the phalanx. This adult has a benign lesion in the phalanx, which is geographic lytic lesion, no cortical break, no periosteal reaction. Okay. Now, once you are clear, I can see most of you are clear. Very good, beta. I am so proud of you. Now, please see. Now, what we have to do is I will zoom the X-ray so that it fills up your entire mobile screen. I will zoom the X-ray so that it fills up the entire mobile screen. And we will try to look inside the disease. Okay. We will try to look inside the disease. Do you think that this disease, okay, is filled up with clear fluid, or do you have any matrix inside? Now, if you have matrix inside, there should be some calcification. Can you see this tiny stippled, punctate, stippled calcific foci? Can you see there are, okay, can you see there are calcific foci inside? Yes, yes. So we can see there is a stippled appearance inside. Stippled appearance on an X-ray of a bone tumor indicates the presence of chondroid matrix. That means I am looking at a benign lesion in the phalanx with chondroid matrix. Do you see why there is a matrix? Because there is calcification. Okay. So anybody who's joining right now, don't worry. We are at the first page and this is the first slide. Okay. So benign cartilaginous tumor of the bone, which is most commonly seen in the phalanges, is enchondroma. This is called as enchondroma. Very good. I can see most of you are able to answer. Very good. So enchondroma, anybody, this X-ray appearance is called as, what is this lesion like? Lesion is appearing like a ring on the finger like this. So we call it O-ring sign. This X-ray appearance is called as O-ring sign. You can call it popcorn also. Still the answer remains that, okay, this is enchondroma. Okay, enchondroma, because cartilage can have variable appearance, can look like dot, 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 can look like arcs and rings. Okay, now tell me, immediately integrated question is coming your way. Let's see if you can answer. A patient has multiple enchondromas. Patient has multiple enchondromas. Okay. Can you name a disease which causes multiple benign enchondromas in the bone? Then you will call the disease as, after the pathologist who described it, we'll call it Ollier's disease. Everybody understands? Ollier's disease. Everybody understands? Multiple enchondroma is Ollier's disease. Okay, now tell me, let's see if you can answer the second question. If you have multiple enchondromas in the bone along with soft tissue hemangiomas, so in the bone you have enchondromas and in the soft tissue you have hemangioma, then we call it Maffucci syndrome, after the pathologist. This is the name of a pathologist who described this disease. Are you clear? Are you clear? Okay. So enchondroma is a benign cartilaginous tumor of the bone, but can be multifocal. If multifocal, think of Olier's and Maffucci syndrome. Everybody understands? Okay. So we will make a small flashcard here. This is what is Maffucci syndrome. Everybody gets it? Very good. Now tell me. Okay. So this is now I am showing you a flashcard in front of you. This is a flashcard showing you X-ray of enchondroma. Okay. But what can you get confused in the exam with? How can you be confused in the exam? So in the exam, how you will be confused is, let us see another X-ray. Okay. Now in this X-ray, first of all, I want you to see all the chota bachas, please see, and even the bada bachas also. This is your growth plate. But I saw some of you were asking, this is growth plate. Growth plate is the gap between the metaphysis and the epiphysis. जो physial growth plate जो cartilage होता है, it's a gap between, X-ray it will be seen as a gap between metaphysis and the epiphysis. This is growth plate. Now tell me, what do you see in this X-ray? If this is your epiphysis, this is your metaphysis. In this immature skeleton, we can see a bony outgrowth arising from the metaphysis, growing in a direction away or pointing or growing away from the joint. Okay. In this immature skeleton, you can see a bony outgrowth. Everybody understand? Bony outgrowth in the metaphysis of a child, growing or showing pointing toward away from the nearby joint. Okay. Now, beta, if I say in Greek and Latin, outward will be written as exo. Bahar ko bolenge exo. Outward is exo. Bone will be ostium. Exostosis. Have you heard of this before? So this tumor, this bony benign lesion is called as exostosis. Exostosis is also called as osteochondroma. So don't get confused in the exam. Enchondroma was different from osteochondroma. Osteochondroma is not a true tumor. Are you clear? Osteochondroma is not a true tumor. It is a bony outgrowth arising from the metaphysis of a child, pointing away from the bone, away from the joint. Okay, let's see if you can answer better. Okay, let's see if you can answer. Okay, rarely in a bone dysplasia called as Trevor's disease, you can have osteochondromas arising from the epiphysis. Okay, rarely in a congenital problem, in a bone dysplasia, you can have osteochondromas from epiphysis as well. Don't forget that. But usually, osteochondromas are seen arising from the metaphysis. Are you clear? So can you have epiphyseal osteochondromas? Yes. Which disease? Trevor's disease. Trevor's disease. Okay. Now it is not considered a true tumor. Enchondroma is a true tumor. This is not a tumor. This is a bony outgrowth happening because of various reasons. Now let's see if you can answer better. Let's see if you can answer. Can you see this here? Okay, I will zoom it better. So even from the tibia on the other side, even from the fibula, can you see there are multiple exostosis? Multiple exostosis? Yes. So that means if you see multiple exostosis, then what will you call it? multiple exostosis, if they are seen, again it is considered a bony dysplasia. This time it is called as diaphyseal achalasia. These bony exostosis, they cause remodeling of the diaphysis. So if you see multiple exostosis, it is considered a bone dysplasia, which is called as diaphyseal achalasia. Diaphyseal achalasia. Okay, now let's come back and see. So Yuvika beta, if you now see, okay, everybody now see, beta, this can you see? I will draw it for you, beta. Can you see this gap? You see this thin gap between where the epiphysis and metaphysis have not fused. This is called as the growth plate. Okay, this is called as the growth plate. Everybody clear? Okay, so we have some questions with us already. If you see a bony outgrowth pointing away from the joint, what will you mark? Exostosis. Is it a true tumor? No. What is it called as? Osteochondroma. Can you rarely have osteochondromas from epiphysis? Yes, in Trevor's disease. If you have multiple exostosis, then it is a bone dysplasia called as diaphyseal achalasia. Or you can say multiple heredity exostosis syndrome, which is correct, but the proper name is diaphyseal achalasia. Don't forget, this is the previous AIMS question also. Okay, now once you're clear. So now please see, in this page, now you have a flashcard forming. Let's see if you can understand my technique. In this flashcard, I am trying to differentiate enchondroma, osteochondroma. Can you see it here? Enchondroma versus osteochondroma. Yes, everybody gets it? So this was, remember I told you this is a child, immature skeleton. Okay, बेटा यहाँ पे नहीं है ना गैप बेटा जी ये जॉइंट है बेटा, ये ग्रोथ प्लेट नहीं है, ये जॉइंट स्पेस है. अभी क्लियर हुआ कि नहीं? है ना, ठीक है ना बेटा. ये गैप जो है ये दो बोन के बीच में तो जॉइंट है, एपिफाइसिस और मेटाफाइसिस के बीच में तो ग्रोथ प्लेट होता बेटा. एवरीबडी अंडरस्टैंड्स? आर यू क्लियर बेटा? थोड़ा सा समझ आया कि नहीं? दो हड्डी के बीच में ग्रोथ प्लेट नहीं होगी, वो जॉइंट स्पेस होगी बेटा. एवरीबडी क्लियर? ओके okay, everybody understands. Yes, now once you're clear, so this was a small flashcard that I made where we discussed about enchondroma, osteochondroma. Now what I'll do is I will show you some typical images which are very frequently asked in the exam. This is one image which is multiple times has been repeated in last 3 NEET. They have always asked this. Let's see if you can answer. Okay, this is a X-ray. Okay, this is a X-ray, tell me, of a child. Again, you can appreciate there is some gap between the epiphysis and the metaphysis. That means this is an X-ray of a child. This is an immature skeleton. Where is the disease located? So the shaft of the bone is diaphysis, end of the bone is epiphysis. So predominantly the disease is located in the metaphysis of a child. Where is the disease located? So disease is actually this. Okay, this is the disease. So if I'm able to make, anybody now tell me, if I'm able to make a border around the lesion in the bone, then how do I describe it? I will say this is a geographic lytic lesion, well marginated geographic lesion. Eccentric or central? It appears central. Now the bone, if you notice, the bone is tubular in the diaphysis. Towards the metaphysis it becomes slightly wider, so that is why it is looking slightly wider, but actually speaking it does not expand. The lesion is not expanding the bone. Okay, and it is not reaching till the growth plate. What are the key features that I have taught you, beta? Can you repeat after me? A child has a metaphyseal, benign looking, centrally placed lesion which is non-expansile, not reaching till the growth plate. What do you call it? This is a benign cyst of the bone. We call it simple bone cyst. In your orthopedics class, they will simply say SBC. What is SBC? Simple bone cyst. Any other name for it? We can also say unicameral bone cyst. Okay, bone cyst. Cysts are usually benign. So it is a benign cystic lesion in child. Everybody understands? Benign cystic lesion in the child. Now the question is, beta, let's see an answer, beta. A very important question is, why this patient, if it is benign, why he might have come to the doctor to get an X-ray done? He was having pain. He was having pain. So when I now zoom the X-ray again, can you see there is a cortical break? Are you able to appreciate there is a cortical break? Now, once I see cortical break, I start getting worried. Am I looking at a malignancy which is invading the cortex? But remember my rule. I taught you a rule. If the cortex is broken, but no fragment is missing, then you cannot call it invasion. You will call it pathological fracture. Now, try and imagine with me, whatever piece has been broken, that piece, like a leaf, has fallen down into the cyst. Can you see? There is no missing fragment. Whatever fragment is broken has fallen down into the cyst. So this is not invasion. If you now notice, this is a pathological fracture that has happened in a benign lesion, and this appearance is called as fallen leaf sign. So that is why making the basics is very important. Once you understand, now there is no confusion. This is not a malignancy. This is a benign cyst. But how will you be sure? Now today you are thinking of MCQ. Later on in life, what will happen is you become a radiologist or orthopedic doctor. A child, his family are now sitting in your clinic and asking you, doctor, he is having pain. Is it something to worry about? Is it benign? Is it a tumor? And how will you answer if you don't know? The key is to understand. Many people, they confuse what is a good doctor. I want you to know today, many people, they confuse, and many children also they confuse. They say, sir, to become a good doctor, I should be a good human being, which is good. I agree. But I want you to know something else, beta. In addition to being a good human being, that everybody actually should be good human being, in addition to it, a doctor should know what he is doing. Knowledge is important. If you don't know, how will you answer on that day? What will you say? Then you will have to talk like a, have you ever seen people who do not know, they will start like, salesmen, and talk like salesmen to the patients that, dekhte hain ji, chai piye, hum batate hain. You have to become good. There is no choice. You have to become good. So that is where understanding how the concept is broken down into pieces is important. Are you able to understand? So now see this one-liner from NEET PG 2019. Fallen leaf sign on X-ray seen in. It is seen if a pathological fracture happens in a simple bone cyst. Everybody clear? Okay? Okay? Very good. Now let's see if you can answer. So now what do we have to differentiate it from? Now I will show you how to differentiate. The key is differentiation, but I want everybody to focus. This is a mature skeleton. You cannot see any growth plate. There is a disease in the epiphysis of the bone. This is your joint, which is reaching till the joint surface. I will say it is reaching till the subarticular margin. It has subarticular extension. Disease is appearing expansile. How do you know expansile? How do you know expansile, beta? Tell me. Because, beta, listen to me. This is the parent bone. This is the disease. Can you see where you have disease, that area has expanded like a balloon, it has expanded. So we'll say expansile lesion, showing appearance which has been popularly called as the soap bubble appearance. Now you will be surprised to know, if you see this disease on a pathology cross section, okay, if you see this disease on a pathology cross section, all you will see is Okay, listen to me. All you will see is multiple tiny breaks here. Okay, but there will be no septae. So actually, whatever septae we see on X-ray are pseudo trabeculation. So it is not a multi-septated lesion. It is not multi-septated. It is looking like that on an X-ray. Actually, when you look at the pathology specimen, you will see only tiny breaks in the cortex because this tumor is benign but can be locally invasive, can be locally aggressive. What do you think we are looking at? This tumor is called as GCT. What is GCT? It is a benign tumor of the bone, can be locally aggressive. Giant cell tumor can also be called as osteoclastoma. Can also be called as osteoclastoma. Everybody understands? Everybody follows this? Very important, beta, very important. So now tell me, listen to me, everybody. Listen to me, everybody. This is like GCT, like simple bone cyst is a NEET PG favorite. GCT is a AIMS favorite. If I look at last 6 year AIMS exam, twice or thrice they have asked giant cell tumor. They've always asked it. So it is like some कुछ चीजें ना किसी को अच्छी लग जाती है. Some examiners they become fond of something and they keep repeating it. So it's very important to know the difference. Now I will ask you is, see my flashcard that is forming in front of you. My question is, okay, beta, but one, if you have to mark one answer, Vishek, then you will say epiphyseal. It's okay that is epiphyseal going on to metaphyseal. I agree. But if I have to say one word, you will say epiphysis. Okay, precisely this is what you need to mark if the choices are not clear. Everybody understands? Giant cell tumor is a epiphyseal lesion. Now listen to me and answer, beta. Everybody listen to me. So now, why this is not simple bone cyst? Because simple bone cyst is seen in children. This is adult because the growth plates are fused. Simple bone cyst is seen in metaphysis. Giant cell tumor is epiphyseal. Are you clear? Simple bone cyst was central. Giant cell is often eccentric. Okay. Simple bone cyst is non-expansile. GCT being a tumor who is expansile. Okay. Okay, understand here or not? Unique ambler matlab it is having a single cavity. Now GCT, when we look at it, looks like a multiseptated lesion. Well, actually it is not. Actually, it is a solid tumor. So when we look at it, is just a X-ray appearance, which is probably because of the micro invasions in the cortex that have happened. That overlapping invasions is giving rise to this trabeculated appearance. Everybody understands? Everybody clear? Okay. Now, once you are clear, but you cannot do these wrong in your exam. They are sure short questions. These are sure short questions, beta. Sure short. Okay. Now, okay. And so this was the simple bone cyst, beta. Some of you were not able to follow it, so I'm again labeling it. It is difficult to see because it is centrally placed. Okay, it's very central and it is not expanding the bone also. The only thing that is there is a pathological fracture. Now, let's see one more image and that will solve the query. Beta, one more image and that will solve the query. Okay, beta, just one more image. What is this? This is your growth plate. Where is the disease? Is it in the epiphysis? Is it in the epiphysis? Is it in the metaphysis? Is it in the diaphysis? So in this immature skeleton, you can see a disease, a lytic lesion, a destructive lesion in the metaphysis of the bone. But the key word here are this lesion appears expansile. It is expanding the bone, and not only is this expanding the bone, it is also reaching till the growth plate. So below the growth plate in Latin is called as physis. So I will say it is subphyseal. Okay. So now in this X-ray, you have a child with immature skeleton, okay, with a metaphyseal lesion which is expansile, multilocular, subphyseal in nature. What do you think we are dealing with? What do you think? So now we will call it aneurysmal bone cyst. We will call it aneurysmal bone cyst. Are you clear, bacha? Now listen to me, beta. Listen to me. Everybody, listen to me. Are you there? Now see. In simple bone cyst, it was a cystic lesion filled with fluid. While an aneurysmal bone cyst, again, it is a benign lesion of the bone, but now it is actually filled with blood-filled spaces. Aneurysmal matlab blood se bhari space hai. So it is vascular spaces here, and the vascular spaces will pulsate. Because the vascular spaces are pulsating like this lesion is expansile. So now you will not forget, aneurysmal bone cyst is a metaphyseal lesion in a child, but it is expansile and subphyseal. It is expansile and subphyseal. Now, how do we know that is this multilocular lesion or not? Let's try to see it by zooming it. Let me try to zoom it for you. Okay. Now, when we zoom it, can you see there are some thin septae visible? Can you see them? Okay, I will zoom it further. Okay, so that you can see it on your mobile screen as well. Okay, can you see them? So there are septae inside. Septae, can you see them? Can you see those septae inside? Okay, so that's why I'm saying multilocular. Because these are vascular spaces, they are pulsatile, and that pulsatility is causing expansion. Can you remember this for me? If a lesion is very vascular in the bone, it would pulsate and it will expand the cortex. Even if it is not a tumor, it's a benign lesion, but it is expanding because of the pulsatility. Okay, everybody understands. What is ABC? ABC is aneurysmal bone cyst. It is a benign lesion with blood-filled spaces, looking like a bone cyst, but it is not clear cyst. It is blood-filled spaces, so we call it aneurysmal bone cyst. Everybody understands? Now, once you can see them again, now I want you to see with me. I have shown you 3 questions: GCT, SBC, ABC. One of them will definitely be there in your exam. So that is why I'm not going into hi-fi things. I am showing you what is asked in the exam. I'm not going for hi-fi things, beta. This is what is asked every year. They will have one X-ray of either giant cell tumor, aneurysmal bone cyst, or no. So now see, aneurysmal bone cyst is not in the epiphysis. If you notice, I am zooming it. The epiphysis is this one, beta. फिर growth plate है, उसके नीचे ये बैठा है. Okay, so aneurysmal bone cyst is a metaphyseal lesion reaching till the growth plate. GCT epiphysis में था adult के, aneurysmal bone cyst metaphysis में है बच्चे के. Everybody understands? Everybody understands? Okay. Now let's see if you can answer. Okay, let's see if you can answer. Now tell me, beta. Now you need to apply your brain and answer. Is this next image, okay, is this next image, okay, adult or a child? This is a mature skeleton. Where is the disease located? The disease is located in the tibia. Where? In the diaphysis of the tibia. Where? It appears to be located on one side of the bone, it is predominantly located on the anterior cortex of the tibia. Okay. This adult has in the tibia diaphysis, anterior cortex, well demarcated but solid lytic sclerotic lesion, but it is geographic, well demarcated. Now let's see. Question number 1 is this giant cell tumor? Are you looking at a giant cell tumor? Anybody? Yes or no? Is this GCT or not? Sir, sabun ke bulbule to hai, looking like a soap bubble. But now you know GCT should be at the end of the bone. It should be epiphyseal. This is diaphyseal. This cannot be GCT. Are you clear? This is not GCT because GCT is an epiphyseal lesion, while here we are able to see a diaphyseal lesion. Okay. Now, second question. Is this aneurysmal bone cyst? Sir, GCT नहीं होता तो ABC होगा ना? Is this aneurysmal bone cyst? The answer is no. Why not? Because ABC is a pediatric lesion. Aneurysmal bone cyst is usually seen in children. It is usually metaphyseal. This disease is seen in the diaphysis of adult. How it can be ABC? Okay. Now tell me, is this osteosarcoma? Is this osteosarcoma? Beta, tell me, is this osteosarcoma? No. Why not? Osteosarcoma will not be well demarcated. This is well demarcated lesion. Osteosarcoma will not be limited to the bone. It will come out of the bone. It will stretch the sharpie fiber. Remember the sun ray appearance causing the periosteal elevation, Codman triangle. There is no periosteal reaction in this image. There is no cortical break. We are looking at a benign looking lesion. This cannot be osteosarcoma. Sarcoma nahi lag raha hai. Then, so if we are not sure, we will call the pathologist. So on the pathology specimen, the pathologist is saying that you have epithelial cells in this lesion. Please correlate clinically. Pathologist कह रहा है इस बीमारी में epithelial cell हैं, clinically देख लो. अरे ये तो हमारी लाइन थी. अब क्या करें? So what do we do now? Now once we see this combination, what is the combination? Tibia location, diaphysis, anterior cortex, epithelial cell origin. Then there is only one tumor. If I make an integrated picture, this is called as adamantinoma. In long bones, remember, adamantinoma in long bones is seen in tibia. Majority of the time, it is seen in the anterior cortex of the tibial shaft, and it is an epithelial rest tumor. It will have epithelial cells. Are you clear? So the answer here is adamantinoma. And now this is the kind of question which AIMS people will love, because otherwise you will think, देखो बच्चे देखो, जो रट के गया होगा ना बच्चा, वो ऐसे सोचेगा, देखो देखो बेटा, देखो देखो, please see with me. Any student who has just rote learning, if you don't understand, you do rote learning. Okay, sir, this is sabun, bulbule, we can see soap bubble, must be giant cell tumor. While the location is not fitting in, the age is, so you have to understand. So that is why we need to learn how to look at, how to think. Okay, the key is not what to think, the key is how to think, so that you can rule out in the exam other choices. This is adamantinoma of the tibia. Are you clear? Okay, okay, very good. Now let's see another one. Can anybody tell me now that you have learned how to see the growth plate, can you tell me, is this a child or is this an adult? Let's look at the next X-ray and tell me, is this a child or an adult? In the next image, we are looking at, tell me, a immature skeleton. This is a child. Where is a disease? The disease is a well demarcated, benign looking lesion in the epiphysis. In the next image, you can see a child with an epiphyseal lesion, a benign looking epiphyseal lesion. Okay. Now the pathologist is telling you, the pathology is telling that this disease on microscopy shows giant cells. What is your diagnosis? The pathologist is telling you that this disease on pathology has giant cells. What do you think? So now it seems as if they are trying to tell you GCT or a giant cell tumor, but remember, GCT is seen in adults. This is a child. This cannot be GCT. So now tell me, which pediatric bone tumor is seen in the epiphysis and contains giant cells? That is called as chondroblastoma. That is called as chondroblastoma, and it is also called as Codman's tumor. Okay, so don't get confused, beta. Codman triangle kahin aur tha. Remember, Codman triangle, Codman tumor alag hai. Chondroblastoma is called as Codman's tumor. It is a giant cell containing pediatric tumor which is seen in children. Okay, and this is the image that you see in front of you right now from my book. This was same to same asked in NEET PG 2019. They asked the same image in the exam. So that is why I'm telling you, many children after the class come and say, sir, radiology में और क्या करना है? So I always tell them, बेटा जो मैंने पढ़ा है वही करना है. Then they are confused. They say नहीं सर कुछ और करना होगा. Nothing. What I'm telling you is what you need to do, beta. Then they get again confused. They say, sir, no, sir, you are telling the chondroblastoma. They might ask you something else. They will not ask you something else. Okay? Trust me here. Because I'm telling you all important things that you need to know as an MBBS graduate. They will not ask you beyond this. Clear? Okay? Everybody understands. Are you clear with this? Codman tumor, chondroblastoma. Now see. Now let us look at this tumor on a pathology specimen. Okay? Okay? Let us look at this tumor as a pathology specimen. Now, on pathology, if these are your chondroblasts, what is the name of the cell? Chondroblastoma. So these are chondroblasts. In this tumor, you have calcium deposit along the chondroblast like this. In chondroblastoma, you have calcification along the cells like this. I will show you, beta. Listen to me, beta. Listen to me. Everybody, listen to me. Can you see around the cells this dark purple color? This is all calcification. So what should I call this? What is the name that the pathologists have given here? So pathology people in chondroblastoma will teach you chicken wire calcification. Which bone tumor shows chicken wire calcification on microscopy? What is the answer? Chondroblastoma. Chondroblastoma shows chicken wire calcification. Now, if I now show you, please see beta, what do you see on the screen now? Now on the screen, you will see a integrated picture flashcard where we have taken pathology and radiology together. The answer is chondroblastoma. So let us revise a little bit pathology here. You might have studied in pathology. Let's see if you can answer. Name a tumor in the body which has chicken wire vasculature. Have you ever heard about a brain tumor where you have chicken wire? Chicken wire देखने बारीक तार की तरह से wire की तरह से cells के आसपास you have that calcium deposits. So that's why it's called chicken wire. Okay, now tell me, chicken wire vasculature is seen in a brain tumor called as oligodendroglioma. Okay, so don't get confused between the two, beta, है ना? Chicken wire calcification pathology में बताया chondroblastoma में, but chicken wire vasculature oligodendroglioma में होता है brain में, not in the, okay, very good, beta, not in the bone tumor. Clear? ये brain में होगा chicken wire vasculature. Okay, everybody understands? Very good. Now let's go further. Let's go further. So now we have seen all the bubbly lesions which are all bubble. Now we go further into other benign lesions of the bone. In bone, you can have some other benign lesions which are very, very important as far as exams go. Okay, listen to me, everybody. Listen to me. Listen to me. Okay, listen to me. Now I want you to look at the femur in this patient, the neck of the femur and the shaft of the femur here. What do you see? Okay, I'm zooming it. I'm zooming it. So the diseased part of the femur, listen to me, diseased part of the cell, beta, chondroblast थे पिछले बारे में, chondroblast नाम था ना बेटा, Abhishek Rana. I told you na, there is chondroblastoma, so it will have chondroblasts. Okay, now let's see if you can answer. Now, in the femur, where you have the disease, it is benign disease. There is no cortical break, no periosteal reaction. Where you have the disease in the bone, that is neither dark, neither white. Can you see? Understand? Listen to me. The disease is neither white nor dark. It is in between the two. So it is neither transparent, neither opaque. It is translucent like a ground glass. So we will use a word, there is a ground glass appearance of the bone. This is what is called as ground glass. Some of you were asking me after the last class, sir, what is ground glass? Ground glass, beta, you might have read about ground glass in pathology also, in hepatitis, where they talk about those inclusions and ground glass inclusions. What is ground glass? I'll tell you. Now, beta, have you ever seen in your house You have windows? Yes. In your house, you have windows? Yes. Windows are transparent so that the light can come in? Yes, windows are transparent. But remember, in some places in the house where you want privacy, you will have a glass which has a matte finish. Remember, a matte finish, because somebody has ground the glass to make it translucent. The light can come in, but people cannot see in. That is ground glass. You understand now what is ground glass, beta? Ground glass is a translucent glass which is neither opaque, neither transparent, in between. Everybody gets it? Okay, beta, let's see. So ground glass appearance of the bone seen typically in femur. What could this be? Now we are unable to understand what is this. Listen to me. We are unable to understand what is this. So we decided to ask the pathologist. So we asked the pathologist, what are you looking at? So pathology people are telling that when you look at this patient's bone, in the area where we had ground glass appearance, we have scattered proliferation of woven bone along with fibrous tissue. There is some fibrous tissue and woven bone. Okay. While remember, in an adult you should have lamellar bone. अडल्ट में तो नॉर्मल में लेमिलर बोन होती है. यहां पे क्या हो गया? प्रोलिफरेशन ऑफ benign proliferation of woven bone and fibrous tissue. Okay, everybody clear? Okay, now the pathology people could not understand what they are looking at. They could not understand what is this fibrous tissue, woven bone, and they were looking at it for long time. If you look at something for long time, whatever is not there also you can start seeing. So the pathologist started to see, as if they started thinking that some alphabet is written here. They said, oh my God, there is some secret message, some alphabets written here. And they tried to read it, but they could not read it. And when they could not read it, the Western people, European people, they become racist. They have some racism in them. So they say, if I cannot read it, it must be written in Chinese. And they say this is called as Chinese letter pattern on microscopy. This is what is called as Chinese letter pattern on microscopy. And this, because of this fibrous tissue and woven bone, that area was appearing glassy, ground glass appearance. Okay, now we have two things with us. We have an X-ray, we have a pathology picture, but we have a man standing here. Who is this man? Let's try to imagine, understand. Now, when we look at the image that I've given you as a clue, this is a sheep. Don't get confused. This is a sheep. So who is this man? If this is a sheep, who is this man? This is a shepherd. This is a shepherd, a smart-looking shepherd from Southern America, from Texas. You can see him. He has in his hand a crook. And whenever the sheep are running, he is able to get those sheep back with this shepherd's crook. Come back. Because of the softening of the femur and a pathological fracture as well, this patient has a femur which is shaped like this. This is called as shepherd. Have you heard of this before? Shepherd crook deformity. Okay, shepherd crook deformity, ground glass appearance, Chinese letter pattern. What do you think we are looking at? This benign bony disease is called as fibrous dysplasia. This benign bone disease is called as fibrous dysplasia. Everybody clear? Okay, everybody clear? Now let's see if you can answer, beta. Any one of you can answer. This fibrous dysplasia is a benign disease of the bone, has ground glass appearance. Typically, you will see it in the neck of the femur, but you can also see it in the craniofacial skeleton. Okay, fibrous dysplasia can also be seen in the skull bone and the facial bone, the sinus bones. So you might read about this in ENT as well. Now, can you have multifocal fibrous dysplasia? So I can use a fancy word and say polyosteotic fibrous dysplasia. Okay, what is polyosteotic fibrous dysplasia? Okay, polyosteotic means multiple bones having fibrous dysplasia. Okay, plus cafe ullat spots, we discussed them last time also, plus precocious puberty. If you have fibrous dysplasia in the multiple bones with cafe ullat spots, precocious puberty, that is called as McCune Albright syndrome. Do you remember, did I mention cafe ullat spots before? Yes, I mentioned cafe ullat spots when I was talking about neurofibromatosis type 1. Okay, now I am saying polyosteotic fibrous dysplasia. You people are so smart, you all know it. Polyosteotic fibrous dysplasia, cafe ullat spots, precocious puberty is McCune Albright syndrome. Everybody clear? People know it all, so smart. So now if you notice, now in front of you, I have kind of created a flashcard talking about the pathology appearance of fibrous dysplasia, and we talked about the X-ray appearance of fibrous dysplasia. So remember, ground glass appearance of the bone is seen in fibrous dysplasia, while we saw ground glass appearance in a chest CT in COVID-19 pneumonia. Don't forget that. Yes, yes, very good. Now I will show you two benign lesions of the bone, which are, you may not think of them in bone, but they happen in the bone. Let's see if you can answer better. My question is, can you have a lipoma in the bone? Is it possible to have a benign intraosseous lipoma? Is it possible to have a lipoma? Yes. Okay. Okay, I think DT has taught you all this. Very good. Now tell me, can you have a lipoma in the bone? Yes. Where? Which bone? Lipoma in the bone is seen in calcaneum. Okay. Lipoma in the bone is seen in calcaneum. Most common location for intraosseous lipoma? Calcaneum. Okay. Most common location of intracranial lipoma? So when I say brain, you can also have a lipoma even in the brain, don't forget, but that is around the corpus callosum, pericallosal. So most common location of bony lipoma is calcaneum. Most common location of brain lipoma is around the corpus callosum. Okay. Now let's see. But sir, which is calcaneum? Let me explain to you. Let's try to understand. This is your tibia. This is talus, navicular, calcaneum, cuboid. Everybody clear? Everybody clear? So this is how you identify the bones. Just don't get confused in the exam. If they just ask you to identify the bone, don't get confused. There is a benign lesion in the calcaneum. Okay, we can see a benign looking lesion, well marginated lesion in the calcaneum. Yes. But it has a characteristic feature which is considered characteristic for lipoma. It has a single calcific center. Did you notice? It has a calcific center in the center of the lytic lesion. Okay. So if you see a benign looking lesion in the calcaneum with a calcific center, this is typical of lipoma. Okay, this calcific center has been found to be very typical of lipoma because lipoma in the bone, the fat anchors around the calcific center. So it has fat all around it. In the center, you have some calcification. This is very typical. So this is called as, beta, I was just talking about brain and a side. अभी थोड़ा सा बोला मैंने गलती से हो गया. Okay, everybody. Okay, in brain, pericallosal ध्वनि beta around the corpus callosum beta. Now let's see if you can answer beta. सोच के बताओ, सुनो beta, listen more beta, listen. Okay, सुनने की कोशिश करेंगे. It's very important. Okay, listen to what I'm saying. All that I'm saying will be asked in the exam. Please listen to me. Calcaneum lipoma is a benign lesion. It looks like a ribbon which has a central dot. You remember such a ribbon? Do you remember such a ribbon that you might have put when you were, some of you might have remembered as a child when you were a prefect of your school, you might have worn this kind of a ribbon on your blazer. This is called as the cockard. So this is called as cockard sign. Clear? Cockard sign in calcaneum is benign, is lipoma. No treatment is required. It is benign. Nothing needs to be done. Everybody clear? Okay. Everybody clear? Very good. So this is what is called as cockard. Cockard sign on X-ray of the calcaneum is seen in lipoma. Okay. Second question. Can you have a hemangioma in the bone? Okay. Question number 2. Can you have a hemangioma in the bone? Yes or no? I can see all of you were prefects in the school, huh? Tell me, all the good boys and good girls of the school, they become doctors. Okay? And all the bad boys and all the children who were not able to pass the school, they become politicians. Okay? You were the prefects and the head boys, and now you're doctors. All the other students that you were giving punishment in the school, they become politicians. Okay? Now let's see if you can answer better. Hemangioma, yes, benign. Benign proliferation of blood vessels. Again, universal. You can have hemangioma anywhere in the body, including bone. Most common bone showing a hemangioma is vertebra. Most common bone, okay, listen to me. Most common bone showing a hemangioma is vertebra. So hemangioma, if you have a hemangioma proliferating in a vertebra, you can only see vertical striated appearance in the vertebra like this. Hemangioma in the vertebra will lead to vertical striated appearance or vertical striations. Again, the importance is it is a benign lesion. You need not do anything. Once the X-ray says hemangioma, you will have to do nothing. Okay, listen to me. Listen to me, beta. Listen to me. Okay, listen to me and tell me. Beta ji, all the intelligent bachas, come back. All the head boys and head girls, kahan gaye? Aajo, aajo. Okay, now can you see? In this vertebra, can you appreciate? I'm trying to zoom it. Can you see these vertical striations? Yes. This vertical striated appearance is called as corduroy. This appearance is called as corduroy cloth appearance. Okay. Everybody clear? Everybody? Okay. Corduroy cloth means corduroy is a kind of cloth that you might have seen in some trousers where you have those lines. So corduroy cloth appearance. Now imagine now, if a disease is line on an X-ray, if I do a CT scan, what will happen? Imagine and tell me, on an X-ray it is like this. When I do a cut section, what will happen? So whatever you see as a line on a cut section, it looks like dot, let's call it polka dot. Everybody clear? So same disease, hemangioma on X-ray. Okay, listen to me, everybody. Hemangioma on X-ray is called as corduroy cloth. On CT is called as polka dot. Okay. So can you have a hemangioma in the bone? Yes, hemangioma can be seen in the bone. Which bone typically shows a hemangioma? Vertebra is the characteristic location. Appearance, corduroy cloth, vertical striations, and polka dot. Let's see now. So we've seen 2-3 benign conditions that you tend to forget: fibrous dysplasia, lipoma, hemangioma. Now let's see the most important X-ray now. Okay. Let's see the next X-ray. Beta, listen to me, and answer the next X-ray. Very, very important. Now, what do you think? This patient has single lesion or multiple lesions? Multiple. Unilaterally, bilaterally? Bilaterally, randomly distributed multiple lesions in the skeleton. Sir, can you show me? I cannot see. Okay, beta, I will show you. These are the lesions, beta. Can you see them? Entire of the skeleton has, listen to me, entire of the skeleton has multiple bilateral randomly distributed lesions. Such random bilateral lesions is telling me that probably I am dealing with some hematogenous spread. This does not look like a primary bone tumor. It looks like metastasis. Okay, it looks like metastasis. Okay, everybody understands? Skeletal metastasis. Now tell me, in bone, there are two cells which are living in harmony. One is osteoblast, other is osteoclast. Listen to me. In bone, there are two cells which are living in harmony. Okay, osteoblast, osteoclast. Everybody listen to me, listen to me. ठीक है? Osteoblast bone बना रहा है, osteoclast उसको destroy कर रहा है. So one is forming the bone, one is destroying the bone. They are living in harmony. Why they are living in harmony? Because there are only two people. So when there are two cells together, they have no politics happening. They are having peace, harmony. Okay. Now what happens is एक तीसरा या तीसरी वहां आ गई. Now their harmony is disturbed by a metastatic cell. वहां पे कोई और आ गया या आ गई जिसको नहीं आना चाहिए था. Metastasis आ गया. Now in bone you had osteoblast forming the bone, osteoclast destroying the bone equally, and now you have another cell which is metastasis. And you might have seen, listen to me, you might have seen in your own friend circle also, when tisra ya tisri comes in, the balance is lost. Now the metastasis will either favor the osteoclastic process or favor the osteoblastic process. मेटास्टेसिस आने के बाद या तो ओस्टियोब्लास्ट का पड़ना भारी हो जाएगा या ओस्टियोक्लास्ट का. बैलेंस खराब हो जाएगा. Okay, so that means metastasis in the bone can lead to two type of appearances. Metastasis in the bone can be osteolytic or osteoblastic. अब समझ आया ऐसा क्यों हुआ? You understand? When I was at your age, I could never understand why in the bone. Okay, if I read your chat, you tend to make me laugh all the time because of you people have a very good sense of humor. Okay? Very good, huh? But don't overdo it, na? Pad bhi lete beta. Huh? Tell me, beta. Huh? My question is, so when I was your age, I could not understand why in bone metastasis is osteolytic and osteoblastic. In some tumors osteolytic, some tumors osteoblastic. Because in bone, two types of processes are happening: a blastic process, a clastic process. And the balance between the process is lost when there is metastasis. And depending on the tumor, either the metastatic lesion will be osteoblastic or osteoclastic. Everybody understands? Okay, listen to me now and tell me. Let's look at the X-ray again and tell me the disease that you're looking at, is this osteoblastic or osteoclastic? Listen to me, everybody. The disease that you're looking at, is it osteoblastic or osteoclastic? This is osteoblastic. So these metastases are osteoblastic. They are white. They are forming bone. So whenever they show me an X-ray like this, I always mark the answer as cancer prostate. Are you clear? Most typical cause of osteoblastic metastasis is, tell me, CA prostate, cancer prostate. Now, second question is, let's see if you can answer, beta. Let's see if you can answer. Oh, I would always mark CA prostate, but if they write in the question, it is a female patient. If they write in the question, it's a female patient with osteoblastic metastasis, तब मैं जिद नहीं करूंगा, and then I will mark cancer breast. Okay. Most important cause of osteoblastic metastasis is prostate, but in a female patient, you should mark cancer breast. Everybody clear? In female, don't mark prostate and come back. Huh? Don't do that. In addition to that, tumors like stomach, carcinoid, bladder, medullary cancer of thyroid. These will also be osteoblastic. So osteoblastic metastasis is seen typically with prostate, which is the most common cause, but can also be seen in breast, stomach, carcinoid, bladder, medullary cancer of thyroid. Okay, now see, osteolytic metastasis is the most common pattern. Okay, again, breast cancer can be lytic and blastic both. Breast cancer can lead to both lytic and blastic metastasis. Lung cancer metastases are typically osteolytic. Okay, most of the cancers are osteolytic. Most of the cancers, when they go to the bone, they are osteolytic. Mostly breast cancer can also be osteolytic and osteoblastic both. But remember, there are some cancers like RCC, I'm saying kidney, RCC, and follicular cancer of thyroid. These tumors, when they go to the bone, these are very vascular metastases. Okay. Any one of you can tell me, listen to me, if a tumor is having metastasis which is very vascular, then what will happen? They will pulsate. They will pulsate. So RCC and follicular cancer thyroid metastases are pulsatile. And on X-ray, they are not only lytic, they are lytic and expansile. Do you remember my concept? If something is pulsating on X-ray, it will look expanded. So which cancers lead to pulsatile bony metastasis when you look at it clinically? RCC. RCC is kidney, renal cell cancer beta, and follicular cancer of thyroid. Everybody clear? These are not only lytic, they will also be expanded. So we'll say lytic expansile lesions. Okay. Now remember, I'm writing something. Metastasis, to detect metastasis, there is an investigation called as bone scan, which is considered better than a X-ray to pick up metastasis. Okay. Later on, towards the end of my classes, I will also talk about PET scan. But right now, you need to know, to pick up skeletal metastasis, okay, you need bone scan is better than a X-ray. Bone scan uses an isotope called as technetium MDP. MDP stands for methyl diphosphonate. Can you remember? Technetium MDP stands for methyl diphosphonate. Everybody clear? Everybody clear? Okay, now see. Now, because it has phosphate inside, it tends to accumulate in the areas of osteoblastic activity. Now, listen to me and see with me. I'm going to zoom the image for you. Don't get confused by this. This is nothing but your urinary bladder, which is excreting the isotope. It must be excreted by the kidney and the bladder. The disease is actually this. Everybody focus on the screen, beta. Don't chat here and there, beta. Look at the screen, beta. Okay, can you see it? Tell me. What do you see? So if you now look at the skeleton, you will find multiple areas of increased uptake, multiple focal area of increased uptake. In bone scan, we call them as hotspots. Okay. And metastasis in the bone, especially the blastic metastasis, will look like hotspots. Okay. So what do you see in the skeleton? We can see hotspots. Hotspots, metastasis. These are metastatic lesions. Okay. But don't get confused. Multiple myeloma on a bone scan is cold. Can you remember this for me? Multiple myeloma on bone scan is cold. Okay. And we all know hot cheese हमेशा दिखाई देती है कोल्ड चीज मिस हो जाती है. So we all know, we all have a tendency to notice hot things easily, pun intended, and we miss cold things. So remember, multiple myeloma is missed on a bone scan. Bone scan is actually considered useless for multiple myeloma, which is a very, very frequently asked question. Very frequently in the exam, they will ask you a question: which of the following investigation is useless to be done in a patient with multiple myeloma? Please mark the answer as bone scan. So now I'm sure you will not forget. Most of the time, metastasis would be hot on a bone scan. Multiple myeloma will be cold on a bone scan. Okay, everybody understands? Now listen to me, everybody. Listen to me. Listen to me. I know naughty boys and girls are able to understand. Yes, now tell me, listen to me, and let's see if you can answer. But some of you are getting confused. Okay, some of you are getting confused. You are confusing bone scan with the DEXA scan. No, beta. DEXA is a separate investigation. DEXA is dual energy. It's a separate machine, है ना? Bone scan isotope से करते हैं. That is separate. DEXA is dual energy X-ray absorptiometry. Where did you read about DEXA? It is the investigation of choice for osteoporosis assessment. Or we can say it is the investigation of choice for bone mineral density. ठीक है? अब समझ पा रहा है बच्चा? जो डेक्सा बोल रहा था, डेक्सा अलग होता है बेटा, बोन स्कैन अलग है. बोन स्कैन का मतलब है आइसोटोप स्कैन जो मेटास्टेसिस देखने के लिए कर रहे हैं. डेक्सा स्कैन का मतलब ओस्टियोपोरोसिस या बोन मिनरल डेंसिटी के लिए. एवरीबडी अंडरस्टैंड्स? Okay, now let's see if you can answer beta. Anybody? Now suppose this is your bone density of a young adult. This is +1 standard deviations. Now don't ask me what is standard deviation. This is -1 standard deviation, -2 standard deviations, -2.5. Okay. So if as compared to young adult, your bone density is less than -2.5 standard deviations, this is called as T-score. This is defined as osteoporosis. This is called as T-score, and this is defined as osteoporosis. Are you able to understand this? याद कर पाएंगे? So what is the WHO definition of osteoporosis? T-score less than -2.5. This means as compared to a young adult, your bone density is less than 2.5 standard deviations from the density of a young adult. Are you clear? This is Z. This is T-score. T-score. And if your T-score is between -1 and -2.5, it is defined as osteopenia. Okay. This is not Z score, beta. Z score mein Haripriya, we will compare with the same age person. Okay. WHO uses young adult as the reference point. So this is called as T score. Kabhi bhulna nahi hai. WHO definition of osteoporosis is based on T score. Okay. I'm zooming it. T score less than -2.5 is osteoporosis, and that these are the kind of patients where you give bisphosphonates. Did you read this in pharmacology? Osteoporosis treatment, bisphosphonates? Yes. Are you clear? While a T score between -1 and -2.5 is osteopenia. Clear हो गया? Clear? याद कर पाएंगे? Z में we compare with the same age, while WHO compares with the young adult. That is why it is called as T score. Clear? Okay, now let's see. Okay, let's see an answer. Okay, so some of you have a question about the why bone scan in this metastasis. I'll come to this point again when I talk about PET scan. So please wait. When I talk about PET scan, I'll come back to this point. So maybe I can finish it here. Pure lytic metastasis, PET scan is better than bone scan. Okay, beta? Okay, बच्चे आ रहे हैं? Now are you clear? So the reason I'm not telling you this is because अभी PET बताया नहीं ना मैंने, इसलिए नहीं बता रहा हूँ. So are you clear? For a pure lytic metastasis, PET scan would be better than bone scan. That I will discuss when I talk about PET scan. I'll tell you again. Okay, everybody clear? Now let's see some classic appearances. Okay, everybody, now we see some classic appearances. Listen to me, beta. Okay, phosphate. Now see, now please see. Okay, in this patient, in the skull, can you see there are multiple holes in the skull? Multiple holes in the skull, we will call it multiple punched out lytic lesions in the skull. Okay, now it looks as if this man went into the rain and but forgot to take an umbrella. That is why you can see some raindrops on his skull. Yes, so we will call it, okay, we will call it raindrop skull. Okay, this is what is the X-ray appearance of multiple myeloma. Multiple myeloma on X-ray of the skull shows punched out lytic lesions, raindrop skull, raindrop skull. The word punched out means that if you see pathologically, this is the outer table of the skull, this is the inner table of the skull. If you see pathologically, like a hole, like a paper punch, you can see a hole going through and through from the inner table to the outer table, destroying both of them equally. This is what is called as punched out lesion. Punched out lesion means it has vertical walls, it is destroying the inner table and the outer table equally. Punched out lytic lesions. Okay. Plus, these patients can also have pathological fractures in the vertebra. Okay. So typically in the question, the examiner will write backache, X-ray shown to you. You need to think that multiple myeloma patients can develop weakening of the vertebra and develop pathological fractures there. Okay. But what about bone scan? Remember, bone scan in multiple myeloma is useless because myeloma lesions are cold on a bone scan. Everybody clear? Okay. Now let's see if you can answer. Now is the difficult part. Okay, this is very difficult. So if you are unable to see this one, that's okay, because it might be difficult to see on the small screen because it's very, very small lesions. Okay. In the next image, please see with me. Can you see in this skull, especially if you look at the cortex, you can kind of make out. Look at the cortex here, skull cortex. Can you see in the bone? Can you appreciate there are very, very tiny holes, very tiny holes. So when we see such tiny holes, this is what is called as salt and pepper skull. Or we use a word pepper pot skull. Okay. So if the holes are smaller, sometimes we may not be able to differentiate. Sometimes we may not be able to differentiate between salt and pepper and multiple myeloma solely on the X-ray. So we need to know the other history and other findings. But if we say salt and pepper pot appearance, please mark the answer as hyperparathyroidism. This is not a tumor. This is metabolic cause leading to bone resorption. Hyperparathyroidism. Very good. But let me ask you a question. What is the earliest X-ray finding of hyperparathyroidism? What is the earliest X-ray finding of hyperparathyroidism? Now you might notice why I am talking about hyperparathyroidism when I am talking about bone tumor, because you can confuse. It may look like destruction of the bone, but it is not a tumor of the bone. It is a parathyroid tumor causing parathormone release, leading to resorption and destruction of the bone. So earliest X-ray feature, characteristic X-ray feature of hyperparathyroidism is subperiosteal. Remember this word. If it is written in the paper, please mark hyperparathyroidism. Earliest causes subperiosteal resorption of the bone, classically involving the second and third digit, middle phalanx on the radial side. Okay. Bony changes of hyperparathyroidism are earliest seen in the second and third digit, middle phalanx on the radial side. Okay, before I go on, just look at the X-ray with me. Just look at this X-ray. Now, please see this side of the bone here, which I'm marking with a red arrow. देख रहे हैं बच्चे? I'm marking the side with a red arrow. That is a normal appearance. This is normal. Now, please see the other side, which I'm marking with a curved arrow. Please see. Do you agree? The side that I have marked with the white arrow looks scalloped. ऐसा लग रहा है जैसे किसी ने आइसक्रीम को ऐसे खुरच दिया. Can you see? You can see there is some scalloping, some small part of bone destruction. That is subperiosteal resorption. So now if you see with the arrows, this is how you identify subperiosteal resorption of the bone. This is the characteristic finding of hyperparathyroidism, earliest finding. Okay. Hyperparathyroidism can mimic a tumor. It can lead to osteoclastic destruction of the bone looking like a tumor. Hence, the pathologists get confused and they call it brown tumor also. Are you aware of this? So, brown tumor is not a tumor. It is a manifestation of hyperparathyroidism. In pathology, it is nothing but osteoclastic destruction of the bone. Are you clear? Another thing to remember here is a word that I'm writing for you is lamina dura resorption. Hyperparathyroidism also leads to resorption of the bone in the tooth socket. Okay, it leads to resorption of the bone of the tooth socket, which is called as lamina dura. Okay, everybody understands? So don't get confused in the exam. So below paper pot skull I had written hyperparathyroidism. Everybody understands? So don't get confused between hyperparathyroidism. It can mimic a bone tumor. That is why in pathology they have used a misnomer, brown tumor. It can lead to resorption of the tooth socket bone, that is called as lamina dura. It can lead to subperiosteal resorption, which is earliest, salt and pepper skull. Okay. Now, let's see if you can answer. Okay. Okay, one more image, and before we go on to some, gradually if you see, I'm, trying to finish off with the tumors of the bone, including the hematological things. Please see with me, and metabolic things, please see with me. This is how a fontanelle of your skull would look like. Okay. This is how the fontanelle of the skull would look like. So may I ask you, if you can see the fontanelle, it must be a child. It must be a child. So in this child, you can see a lytic lesion in the skull here, a lytic lesion in the skull here, a lytic lesion in the skull here. What do you think? In this child, the sutures are open, the fontanelles are open, and you can see multiple lytic lesions. Any one of you, do you think these are looking like raindrops? Do you think these are like raindrops? No, these are not raindrops. They don't look like a raindrop. No. Raindrop itna bada kaise hoga? Do you think it is like pepper, salt and pepper? No. What is this? Now, to me, it looks like maybe this is the African continent. Maybe this is the European continent. This is the Asia. They're looking like maps. So such map-like appearance, map-like destructive lesions have been called as geographic skull. So So you can see multiple lytic lesions in a child with a map-like appearance. We call it geographic skull. These lytic lesions, if you look at them in pathology, you will discover these lytic lesions destroy the outer table of the skull more than the inner table. This is called as lytic lesions with beveled edges. Can you name the disease? Can you name a disease? Okay. Anyone? Can you name the disease? Name a pediatric disease which leads to large map-like lytic lesions in the skull. And this is again given in pathology, but nobody reads it in pathology. Okay, everybody misses it in pathology. Okay, this is called as LCH. What is LCH, beta ji? Langer-Hensel histiocytosis. Okay, so lytic lesions in the skull of an adult, we think of multiple myeloma. In a child with beveled edges, keep it in mind, Langer-Hensel histiocytosis. This LCH can also be written as, don't get confused, it is synonymous, eosinophilic granuloma. Everybody clear? It can also be written as eosinophilic granuloma. Everybody clear? Okay, beta. Now let's see if you can answer. LCH can also lead to a vertebra getting collapsed. If these are your vertebra, this is your disc. So can you see one of the vertebra, because of Langer-Hensel histiocytosis, has totally fractured and collapsed. And because of the collapse, it has become so flat, so plain that we call it vertebra plana. Okay. Now, if you notice on this page, you have Langer-Hensel histiocytosis. On the spine X-ray, it can lead to a solitary vertebral collapse called as vertebra plana. In the skull, it causes geographic skull. Okay. Okay, it's a pediatric disease, but it will be seen in children. Okay, so now see, let's see if you can answer. Now two tough questions. Let's see if you can answer the two tough questions. Suppose in patient with LCH, you have skull lytic lesions along with diabetes insipidus, along with this histiocytosis leading to exophthalmos. What will you call it? Suppose you have histiocytosis causing skull destruction, in histiocytosis in the infundibulum area causing diabetes insipidus and exophthalmos in the orbit. What will you call it? This is what is written in your pathology book as Hand-Schuller-Christian disease. Okay, many students, they miss it in the exam, but keep it in mind. This triad is called as Hand-Schuller-Christian triad. Very good. Now let's see if we can answer one more question. Can you have LCH, Langer-Hensel histiocytosis, in the lung? Is it possible to have LCH in the lungs? भाई बोन में तो बच्चे में मैंने बताया कि हड्डी में होता है, स्कल में होता है, but can you have LCH in the lung? Yes or no? Again, when you will go back, you will find it. It is written in Robbins, it is written in your Harrison, but nobody is reading this. LCH can happen in the lung, but typically in smokers. LCH of the lung is unique that it has association with smoking. While LCH of the bone was a pediatric condition, had no relationship to smoking, Langer-Hensel histiocytosis in the lung has association with smoking. Okay. Now we do not know what is there in the cigarette smoke which causes proliferation of this Langer-Hensel histiocytes in the lung. Now remember, whenever somebody is smoking, the smoke, remember, smoke goes up. Okay, remember, I'm sure आपने एक picture में भी देखा होगा, धुआं ऊपर जाता है, राख नीचे जाती है. Remember, so smoke goes up. It goes to the upper lobe of the lung. And you develop upper lobe predominant nodules, and later on the nodules become cysts, so cystic disease. Okay, so LCH is seen in smokers as upper lobe predominant young adult with upper lobe predominant young smoker, upper lobe predominant nodules and cysts. Please keep it in mind, the answer might be LCH, which many people may not suspect. Are you clear? Very good. I can see some of you are able to answer. Very intelligent students. Okay. And I'm sure you might have read about this in pathology. LCH on electron microscopy shows tennis racket shaped granules, which are called as Burbeck granules. Okay. LCH on electron microscopy shows, beta मैंने बोला ना अरविंद, bony LCH is seen in children, pulmonary LCH is seen in young adults, and nobody suspects it and people miss it. That is what I said, Aravind. Everybody gets it? Okay, very good. Now, once you are clear, let me now take you further into the further part. Now, so far we saw the tumors of the bone, benign, malignant, we saw chondroid tumor, osteoid tumors, we saw hematogenous, histiocytosis, we saw multiple myeloma, we saw, metabolic condition. Now, what I want you to tell me is infection. Infection of the bone is called as osteomyelitis. So suppose I write here, okay, maybe we can take a blank page here. Suppose I write here acute osteomyelitis. Can any of you tell me what is the earliest X-ray feature of acute osteomyelitis? Earliest X-ray feature of, earliest X-ray feature of acute osteomyelitis is only soft tissue swelling. Which can be written as blurring of tissue planes. Okay. Earliest X-ray feature of acute osteomyelitis is soft tissue swelling, which can be written as blurring of the tissue planes. Are you clear? Immediately a question forms. If initially we only see soft tissue swelling, then bony destruction is seen after. So bone destruction on X-ray is only evident after 7 to 10 days. Bony destruction is evident after 7 to 10 days. But this is not my question. This is just to warm you up. My question is, what is the investigation of choice for acute osteomyelitis and why? Now, if you can answer, the concept will be complete that we started earlier as well. Now, X-ray is not the investigation of choice for osteomyelitis because it cannot tell you that the bone is involved for the first 7 to 10 days. It cannot tell you. So now, how will you diagnose osteomyelitis? So, investigation of choice for acute osteomyelitis is MRI. That is the key word, MRI. Why? Because MRI can show you bone marrow edema as early as 24 hours of onset. Everybody clear? Everybody understands this? Investigation of choice for acute osteomyelitis is not X-ray. X-ray may not be able to show you. We will do a MRI, which can show you marrow edema as early as 24 hours. Now, anybody remembers, to demonstrate bone marrow edema, what do we need to do? We need to suppress the signal of the fat. Anybody remembers a fat suppress technique that I taught you in the class? Fat suppression in bone is done by an MRI technique called as stir. Do you remember? Remember we talked about this? Now, T2 weighted image with fat suppression is stir. Now, remember and understand, infection goes into the bone. Infection is our enemy. In response to the enemy, you will have a war called as inflammation. Inflammation will lead to capillaries leaking, and that will lead to edema in the vascular part, which is the bone marrow. Everybody understands? So this is where the MCQ is. Every year they keep asking, acute osteomyelitis, IUC, MRI. Everybody clear? Very good. I can see most of you are able to answer. Now let's see. Now, if the infection continues for a long time, if the war is going on for a long time, now what will happen? The infection will damage the bone and extend outside the bone with some pus forming there, and that will lift up the periosteum like this. So if this is a chronic disease, inflammation would lead to some dead WBCs. What is that dead bacteria? Subperiosteal abscess formation. When the disease goes long term, it starts to form subperiosteal abscess. Okay. Now, do you know periosteum has a function of giving blood supply to the underlying bone? Periosteal vessels, they supply the underlying bone. Do you remember this or not? Yes. So bone receives blood supply from the periosteum. So now what will happen is, if you have abscess below the periosteum, if you have pus below the periosteum, the blood supply of the underlying bone will start to suffer, and this part of the bone will start to die. This part of the bone, which is now dead, is called as sequestrum. Okay, it is called as sequestrum. Do you remember dead bone in X-ray is called, in osteomyelitis, called as sequestrum? And remember, sequestrum is the hallmark of chronic osteomyelitis. You should not get these basic questions wrong. If you get them wrong, you will not be happy with yourself. So what X-ray finding is characteristic of chronic osteomyelitis? Sequestrum. Sequestrum is the dead bone. ये मिल गया तो पैथोगोनोमिक है chronic osteomyelitis का. Everybody understands? Everybody follows? Okay, let's see if you can answer. Now, in our bone, try and imagine if this is your bone, this is your blood. Blood has a calcium level. So from bone, mineral is taken away to maintain the blood calcium level. So bone is forming the mineral, and constantly the blood vessels are taking that mineral to maintain the blood calcium level, to maintain this homeostasis. Now imagine now the blood vessels are trying to steal the mineral away from the bone to maintain the blood calcium. Now if there are no blood vessels and if this part of the bone is dead, what will happen? Tell me. If there are no blood vessels, demineralization that happens in a normal bone will not happen. So that means dead bone on a X-ray will appear more dense. समझ पा रहे हैं बेटा? अब गलत कर देंगे नहीं तो. Sequestrum will appear more white. It is dead bone, but it will appear more dense. Why? Because a normal bone continuously undergoes some demineralization, which does not happen in the dead bone. So sequestrum appears more dense on a X-ray. Are you clear? Everybody understands? More white. Now see if you can answer. Now what will happen is, the periosteum will try to contain the infection. Now infection is an attack. अब जो attack हुआ है, so body will try to contain it. So periosteum will start forming new bone to stop the attack. उसको फैलने से रोकना है, so we will start forming new bone. This subperiosteal new bone that is formed in chronic osteomyelitis is called as involucrum. Okay, everybody understands? This subperiosteal new bone formation is called as involucrum. But the characteristic finding is sequestrum beta. Okay, anybody in chronic infection because of pus, listen to me, sometimes a piece of periosteum might be necrosed. So what happens is, involucrum in between has holes where the bone formation has not happened. This hole is called as cloaca. So the hole in the involucrum is called as cloaca. This cloaca, now the pus and the dead bone, the body wants to excrete the pus and the dead bone away. A body wants to throw it away. So the dead bone and the pus with pressure is thrown to the surface of the skin, and you form a chronic discharging sinus. So the history will say, patient comes to you with a chronic discharging sinus. So this will be the presenting history, but the X-ray, the hallmark should be a dense piece of bone called as sequestrum. Okay, I will show you, but I'll show you the X-ray. That is why I'm teaching you the basics, so that when I show you the X-ray, you are able to understand. Now tell me, what did I teach you? These are the X-ray findings of chronic pyogenic osteomyelitis. These are the X-ray findings of chronic pyogenic osteomyelitis. My question is, chronic तो TB भी होती है. So why it is not tubercular osteomyelitis? Why pyogenic? What is the difference between an X-ray of tubercular osteomyelitis and pyogenic osteomyelitis? Anybody? Okay. अब TB तो पढ़ना ही पड़ेगा ना? Anybody? Now let's see if you can answer. Tubercular osteomyelitis is characterized by osteoporosis of the bone. The involved bone is severely osteoporotic, but usually you have almost nil periosteal reaction, almost nil new bone formation. While in pyogenic osteomyelitis, you have florid new bone formation. ठीक है बेटा? पायोजेनिक में न्यू बोन फॉर्मेशन बहुत होता है, ट्यूबरकुलर में ना के बराबर. So tubercular osteomyelitis on X-ray shows osteoporosis, exuberant osteoporosis in the involved bone with almost no periosteal reaction, no new bone formation. And that is why sometimes in the Western countries they miss tubercular infections because they are not used to seeing it. They might not think about it. Okay, so that is why sometimes children also miss it in the exams. This is the difference between pyogenic and the tubercular osteomyelitis. Now let's theory we have seen. Let's go to the X-ray and let's look at an X-ray. Okay, let's look at an X-ray. Okay, let's see practical better. Huh? Okay, everybody now look at the screen. Everybody look at the screen. Yes, now see. Can you see with me? In this bone, can you see this chalky white area? In this bone, can you see there is some chalky white area? This chalky white area is the sequestrum. Dead bone, more white. And along the surface of the bone, you can see exuberant new bone formation, florid new bone formation on either side, that is involucrum. Okay, that is involucrum. What is your diagnosis? Chronic pyogenic osteomyelitis. Chronic pyogenic osteomyelitis. Okay, RX matlab beta reaction, periosteal reaction, Anudeep. Okay, can you see now? Sequestrum मैंने सिखाया ना, ज़्यादा white दिखेगा. Okay, so you can see it now. Sequestrum, involucrum. This is chronic osteomyelitis. Pathognomic finding for chronic osteomyelitis. Sequestrum. Florid मतलब बहुत ज़्यादा बेटा. Florid मतलब बहुत ज़्यादा. Okay, everybody clear? Now you can understand. Now let's see if you can answer. Now I will try to confuse you a little bit. Let's see how many of you are able to answer the tough question that I am bringing it to you. Okay, this is your femur. This is your patella. This is your tibia. Okay. Where is the disease located on this X-ray? Is it in the femur? Is it in the tibia? It is in the tibia. Now, when I look at this tibia, the key thing I see is in the upper end of the tibia, you have sclerosis. Can you see it is appearing very white? Sclerosis. So upper end of the tibia is sclerosed. It is very white. Okay. But second thing I want you to notice is, although there is sclerosis, when we look carefully, we can appreciate there is a small ill-defined lytic lesion. So now we have a patient with a small lytic lesion in the upper end of the tibia with surrounding sclerosis. Okay. Let's see if you can answer beta. Some of you might be able to answer beta. Lytic lesion banega jab, suppose karte, let's try and understand. Suppose there is some infection in the bone, destruction happening, okay, the inflammatory process destroying it, so that will cause the lytic lesion. But sclerosis in the bone, if you see density increase in the bone around it, that would happen when there is healing. Now my question is, healing या sclerosis is seen in chronic disease, lytic lesion is seen in acute disease. लिटिक लीजन तब होगा जब बीमारी एक्यूट है, हीलिंग तब होगी, स्क्लेरोसिस तब होगा जब क्रॉनिक है. Now how it is possible? Let's see how it is possible that you have both acute and chronic process happening together. That tells me that this is a subacute osteomyelitis. This subacute osteomyelitis was described by Dr. Brody. So we call it Brody's abscess. Typical location, upper end of the tibia. Typical location, upper end of the tibia. Everybody understands? Brody's abscess is a subacute to chronic. Some books describe it as chronic, some as subacute, but single best answer is subacute osteomyelitis. Okay. Another point I want to just make a small point here, just to remember. Don't go into details. Just remember one line. Today on MRI, if you see a Brody's abscess, it shows an appearance called as penumbra appearance. Just remember the name and don't do anything else. Just remember the name. Brody's abscess on MRI of the bone shows penumbra sign. Okay. Ishika Singh, beta, I told you tubercular osteomyelitis will have osteoporosis with lack of periosteal reaction and lack of new bone formation. Okay. Everybody understands? Very good. Now let's look at one more image. One more image. Let's see if you can solve my query here or not. Okay. This is the, any one of you can tell me, this is the MRI of the spine. These are your vertebra. In between you have your disc. This is your spinal cord. Okay. Any one of you can tell me, why are the vertebra appearing dark? Why are the vertebra appearing dark? The vertebra are appearing dark because this is an MRI. But sir, you told me the fat in the bone will appear white. Okay. This is a fat suppressed MRI. Any fat suppressed technique that we know? Stir. This is a fat suppressed MRI of the spine. But sir, if it is fat suppressed, why are these two vertebrae appearing bright? Can you notice? There are two vertebrae and intervening disc are appearing bright. Two vertebrae and intervening disc, and there is some abscess in the front of the vertebra also. So two vertebrae are appearing hyper intense, they are appearing bright, they have edema, there is edema in the disc, and there is surrounding abscess. This is called as spondylodiscitis. Spondylo means vertebra, disc matlab disc, itis matlab inflammation. Can you name a disease which causes spondylodiscitis? Tuberculosis. What do you call it otherwise? We call it pot spine. Investigation of choice for port spine is MRI. Everybody understands that in a fat suppressed image, if the vertebra is still appearing bright, it must having edema because fat you have suppressed. So if two vertebrae are having edema and the disc is also involved, we call it spondylodiscitis. And so on tuberculosis, investigation of choice for port spine is MRI. First X-ray sign of port spine is, anybody remembers? First X-ray sign of port spine is loss of disc space. The reason is mostly TB is commonly paradiscal, so it involves the disc very early in the disease. So remember, earliest X-ray feature of port spine is loss of disc space, while port spine is best picked up. Investigation of choice for port spine is MRI. Everybody gets it? Yes. MRI is not the gold standard, it is the investigation of choice. बेटा gold standard यहाँ पे biopsy होगी, लेकिन आम तौर पे जिससे diagnosis बनाते हैं, that is IOC is MRI. Okay, very good. So this is how we can understand and answer tuberculosis also. Now, one look at the next X-ray. Can you guess what is it that I'm going to show you? One look at the next X-ray. I'm sure some of you are able to guess that I'm going to now talk about X-ray findings of rickets. X-ray findings of rickets. Okay, let's see if you can answer. Okay, now suppose this is the bone of a child. This is your metaphysis, this is epiphysis, this is growth plate. Okay, now rickets is because of vitamin D deficiency. Vitamin D in the bone is needed for mineralization of osteoid. So bone formation happens in two steps. There is osteoid formation and then mineralization. Because of vitamin D deficiency, mineralization is defective. If the mineralization is defective, this is your cartilaginous growth plate and this is your metaphysis. So if there is vitamin D deficiency, the margin between the growth plate and the bony metaphysis is lost. Understand? Because the vitamin D is not there, so there will be no mineral deposit. So the sharp margin that you see between the epiphysis and the metaphysis is lost. This is called as, so the first X-ray sign of rickets is called as loss of provisional zone of calcification. Okay, so anytime you see a question in the exam saying what is the first X-ray sign of rickets, what will you mark? Loss of provisional zone of calcification. They will not ask you to identify, only a named question. If they show you rickets, they will show you advanced rickets, which I will explain how to identify. But early sign is loss of provisional zone of calcification, which you may not be able to see, as a child, as a medical student, but this is the first sign. Now what happens is, try and imagine with me, at the growth plate, osteoid is accumulating, but it is not getting mineralized. So if this was your cartilaginous growth plate, you have osteoid accumulating, but it is not getting mineralized. There is accumulation of unmineralized osteoid. Okay, so if there is accumulation of unmineralized osteoid, what will happen to the growth plate? Anybody now? Think of it. Kashtu beta, think of it beta. बेटा पहली बार थकते ही अगर छोड़ देगा तो फिर आगे कैसे जाएगा बेटा, है ना? ऐसे थोड़ी. Now tell me. So now because of accumulation of osteoid at the growth plate, the growth plate will become widened. Anybody clear now? So whenever they write in the exam growth plate widening, they are actually telling you about rickets. Growth plate becomes widened. Very good, but I can see a lot of people are able to answer this. Growth plate become widened. Now, little bit more understanding. Now your metaphysis in rickets is soft because the bones, rachitic bones are soft. So whenever the child is doing some weight bearing, जब भी वो कोई काम कर रहा है, the metaphysis पे, the osteoid will push against the metaphysis and the metaphysis will become remodeled and it will become like this. So sorry, because of the weight bearing and the pressure because of the weight bearing, the metaphysis will become broadened. This is called as splaying. सुना था? फैल गए. So it is splaying, and they will become not only they will become splayed, the metaphysis will also become, anybody, rounded. So this rounded metaphysis will be called as cupping, and the border will be irregular. We call it fraying. So in rickets, the metaphysis will show splaying, cupping, and fraying of metaphysis. Let me show you how it looks like now. Okay, before we go further, let's see how to identify. So because in the exam, if you are unable to identify rickets, you will not be happy with yourself. Hai na? Identify the disease this child is suffering from. Please see with me, beta. Look at the growth plate. The growth plate is looking widened. Look at the ulna. Look at the radius. What has happened? Splaying, cupping. Look at the margin of the bone, like a brush border, irregular fraying. Okay, so these are all X-ray findings of rickets. So rickets is something that, if they show you in the exam and you don't know, then even in your final prof or third year they might fail you if you don't know. They say, यार इसको rickets ही नहीं आता है. अभी तो बड़ा genetic disorder पढ़ रहा है and he knows nothing about rickets. So rickets is something which is a spotter. We need to know. Spotter मतलब देखते ही पता है. Growth plate widen, metaphysis is broadened, fraying मतलब irregular हो गया बेटा. Now can you understand? हिरवा बेटा, can you see this is fraying बेटा, जो brush border जैसा हो गया ना बेटा, this is fraying. Okay, fraying and splaying मतलब फैल गया, cupping मतलब गोल हो गया. Everybody understands? This is what is called as rickets. Now anybody now, suppose I give vitamin D to this patient, what will happen? Suppose I give vitamin D to this patient, now what will happen? Now beta, एक बार बताओ, anything that is lost first will recover first. So if you give vitamin D to this patient, listen to me, cupping मतलब metaphysis का गोल होना बेटा. ये देखना, ये metaphysis है ना बेटा, ये जो गोल हो गया ना, इसको कहते हैं कप की तरह. Okay, now anybody, now let's see. So loss of provisional zone of calcification was the first sign. So in healing rickets, first to recover is provisional zone of calcification. भाई जो पहले गया वही पहले आएगा. So when you give vitamin D, you start to see a white line after the growth plate like this. In healing rickets, it is called as white line of Frankel. Are you clear? So in healing rickets, you will see recovery of the provisional zone of calcification, that is called as white line of Frankel. Okay, so we can say happy birthday Shweta, how are you doing? And all these children who are now celebrating birthday. So I have kept my class specifically at this time so that I can personally wish all of you happy birthday. Okay, and that is why I don't finish it before 12, otherwise we will miss the fun of happy birthdays and the cakes and the pastries. Okay, good morning everybody, good morning. It is still morning. Okay, don't worry, just tell me, white line of Frankel is seen in rickets? No, it is not seen in rickets. It is only seen in healing rickets. not in rickets beta. Okay, if you mark rickets it will become wrong. Happy birthday Simran as well. Okay, now let's see if you can answer. Now I will try to confuse you with some questions. Let's see how many of you are able to answer this. Okay, some easy question, don't worry. Epiphyseal enlargement is seen in anybody. Epiphyseal enlarged Vijit Jain as well. Brijesh, Vijit. Okay. Now tell me. Epiphyseal enlargement is seen in most children when they are giving the exam, because they are tired in the exam, they say अरे rickets ही होगा, सर ने बोला तो था ना उसमें बड़ा हो जाता है. बेटा सर ने बोला था वहां ग्रोथ प्लेट बड़ी हो जाती है, एपिफाइसिस नहीं. Okay, it is not the epiphysis which become enlarged in rickets. Answer is not rickets. So epiphyseal enlargement is, बेटा आयुष विनोद तो कोई है ही नहीं क्लास में, ऐसे क्यों कह रहे हैं ना, don't do. Okay, anybody. Epiphyseal enlargement is not seen in rickets. Now why would you have epiphyseal enlargement? Now let's see an answer. Suppose this is the child bone epiphysis of the other side, and this is the joint of a child. Okay, this is the joint of a child. Suppose you have a seronegative मतलब होता है rheumatoid factor negative है. Suppose you have a seronegative inflammatory arthritis of a child, which is called as JRA. JRA क्या होता है? Juvenile rheumatoid arthritis. Okay. I want everybody to think with me. मुश्किल है, but एक बार सोचोगे ना, you will always get it right. Suppose you have a seronegative inflammatory juvenile rheumatoid arthritis in a child, you will develop inflammation around the joint of a child. Okay, just beta, just 2 points and I'll finish off. Okay, just have patience beta बस 2 मिनट और यार, 2 मिनट ना बेटा, बस 2 मिनट. हाँ, okay. So inflammation will lead to hyperemia, increased blood flow. So the epiphyses of a child are growing. Epiphyses of a child are growing. And if because of inflammation you have increased blood flow, what will happen? Anybody? If you have increased blood flow, the epiphysis will become enlarged. So now please understand this classic mistake that many people do without understanding. Epiphyseal enlargement in an X-ray of a child is juvenile rheumatoid arthritis. It is an inflammatory arthritis of children, which is seronegative, and the epiphyses become large. And most students who do not understand this, they will mark, tell me, they will mark rickets, while the answer is juvenile rheumatoid arthritis. Okay. Second confusing thing is, okay, just 2-3 rickets confuser we will do and then we'll go home, is name a condition which leads to epiphyseal dysgenesis. Epiphysis ठीक से नहीं बने. Then what do you think? Epiphyseal enlargement was JRA, but again septic arthritis also, beta, same concept will be there. Very good, beta. So Sai Darshan, very good. Now anybody, epiphyseal dysgenesis, I will now, Lord Deepthi is now coming in my class, but I am not doing it. Please wait. So the epiphyseal dysgenesis again is not seen in rickets. It is not a finding of rickets. It is seen if you do not have thyroxine as a child. So this is seen in hypothyroidism. Epiphyseal dysgenesis is seen in hypothyroidism, or they can say cretinism. Okay. What else do we see in hypothyroidism? Hypothyroidism, the X-ray will also show delayed bone age, and you will see prominent sutural bones in the skull, described by Dr. Worm. So we will call them Vermian bones. So again, reminding you, growth plate widening was rickets, epiphyseal enlargement was juvenile rheumatoid arthritis, epiphyseal dysgenesis was hypothyroidism, cretinism, delayed bone age, hypothyroidism, Vermian bones in the lamboid suture of the skull, okay, is also cretinism. Okay, everybody understands? Now the final question of the day. If vitamin D deficiency happens in adults, then we will call it osteomalacia. Now tell me, will you see growth plate widening in osteomalacia? Will you see growth plate widening in osteomalacia? Answer is no. Growth plate तो बंद हो गई ना, ये तो adult है. Okay, do you understand? Osteomalacia, we are looking at a adult. So adult, we will look at a X-ray of pelvis. Especially we will look at pubic rami and neck of femur. Especially we will look at pubic rami, neck of femur. Just I'm about to finish, better don't worry. I'm just finishing the vitamin D part. So if these are your pubis and pubic rami, pubic symphysis, pubic rami. Okay, listen to me everybody. Listen to me बेटा, आखिरी 10 मिनट में जो पढ़ाऊंगा वही पेपर में आएगा, ध्यान दे दो बेटा, बहुत जरूरी है. Okay, now see, if you have vitamin D deficiency, the mineralization of the bone will be defective. So what will happen is, wherever you are having weight bearing stress points in the pelvis, symmetrically on both sides, you start developing areas of unmineralized osteoid. Okay. Now again answer. Everybody listen to me. Okay. In osteomalacia, symmetrically in your pubic rami and neck of femur, you will see islands of unmineralized osteoid. Okay. यहां पे जो ओस्टियोइड है वो मिनरलाइज नहीं होगा. अब एक्सरे पे क्या दिखेगा? Now on the X-ray they will look as if there is a break in the bone, but there is no break, so we call it pseudo fractures. Osteomalacia में X-ray पे मिलते हैं pseudo fractures. Everybody understands this? Which were described by a man that you will not believe. This man and mummy papa had no hope with him. He was called as loser. So after him we call them losers zones. And another man which was called as Dr. Milkman, इसके मम्मी पापा को भी ज्यादा उम्मीद नहीं थी, so we call it milkman's fractures. These are all three are synonymous. Everybody gets it? Pseudo fractures, loser zones, milkman fractures are pathognomic of osteomalacia. These are symmetrically seen islands of unmineralized osteoid seen in osteomalacia. Another thing that happens in osteomalacia is, if this is your hip joint and this is, I'm about to finish the class, you can start packing your bags, you're about to go home, you already are home. Okay, wait. So if these are your hip joints, in osteomalacia, I think Deepthi is trying to deviate you all the time, but see, this is acetabulum. Next class, I will make sure at 9:30. Okay. Now see, if your acetabulum is soft, because of osteomalacia, the hip will start to protrude into the pelvis and your pelvic cavity will become triangular. This is called as triradiate pelvis. This is called as triradiate pelvis. Everybody understands? And if your vertebra are also soft, because of your weight, the vertebra will be compressed from top and bottom like this, which is called as biconcave or codfish vertebra. Everybody understands? Is that okay? So these are very important questions. Okay, these are very important questions. Okay, so osteomalacia, the hallmark of osteomalacia is pseudo fractures, loser zone, milkman fractures seen in pelvis, in the pubic rami, neck of femur. Pelvis will be having a triradiate shape. The vertebra will be having a biconcave codfish-like appearance. Everybody understands? Okay. Now because I can see exaggerated responses in the class, let us conclude the class here. But before we go, I will show you a small clip to understand. Now see, now when you will be revising your radiology later on, I will give you a suggestion here that in your eMedicos app, I have created for you a product called as Talking CRS. So listen to me. When you go and you start using the Talking CRS, you will see, okay, you will see like this. I would have labeled the entire book on whatever points you need to know and how you have to study. So please, whenever it is just, maybe 1.5 hours of my recording, but you can read the theory along with my guidance. So please do not read CRS without the Talking CRS, because then you will take a lot of time. But when you read the CRS with the Talking CRS, you will be able to revise radiology in 1.5 hours. Okay. Okay, so it's very easy to revise radiology in a very fast manner using the Talking CRS. Keep the CRS in your hand, open the Talking CRS on the eMedicos app, and just see whatever I am marking and whatever I am saying on the video. That is the important part of you. Please don't, it is on your eMedicos app in publication section. Okay, so don't miss out on it. A lot of students, they do not know this because in the eMedicos app, there is so much resource. So many people, they miss it. This is free for all of you regular and foundation students. Not free for all, but free for all DAB students. Okay, everybody understands? So when you go to eMedicos, you try using radiology Talking CRS. You will become addicted to it. It is very easy to read and very fast to read all this. Okay, so with this, we come to the end of this class, and in the end, my message to you today is, okay, the message that we have already discussed multiple times. I will now again say that anything that you do with full focus, with full attention to the task, magic happens. Focus is very important. So I keep seeing many children, they keep deviated in between, but if you understand, focus is like a lens, and this is a paper. So normally sunlight cannot burn the paper, but if I keep a lens and the lens will focus the power of the sun onto the paper will burn. The key is in focus. More you focus on your task at hand, more you focus on your studies, better you will become, more you will be able to understand, and you will create magic, just like the lens. I wish you all the best. The key message for today is focus. I wish you all the best. I will see you in the next class. In the next class, I will cover and finish the bones. I will now ask, Dr. Deepti also to say a quick good night to you.
Yeah, I just couldn't say goodbye earlier. So goodbye, everyone. Thank you for being very, very good students. And thank you for being with me without any names. All right. So all the very best. Take care. You have a class in the morning. Sweet dreams, everyone.
Take care, and you will enjoy the tomorrow's class. Dr. Achin, he tries his best. He works very, very hard to keep you entertained as well as, informed. We always try our best to balance it. I wish you all the best, and we are very, very, very proud of all of you.
Good night, everyone. Okay? Take care.
Good night. Take care of yourself. God bless.